Yeah, good evening. Dr. Elavanil, we can get started. It's 8. Good evening, everyone. Welcome to season 3 of Ask Your Mentor. A brief introduction about this program. We started this way back in the year 2020 to help and extract trainees in all the subjects and whatever doubts they had. So we thought of this novel idea to clear their doubts, whatever it might be, with literature support, with proper scientific support. And here we are in the 3rd year in succession, and due to the fantastic feedback that we have received from the trainees. And I'd like to take this opportunity to thank the President, Dr. Krishna Kumar Raja, and the fantastic team behind this program, Dr. Sasikala, Dr. Elavanil, and Dr. Kalpa Pandya, who has been working tirelessly
Sir, we are not able to hear you.
Yeah, okay. That was missing. Yeah. One. He's there. Sir, KK sir, if you're there, can you have a few words from you? KK sir, are you there? Okay, I think we'll at the end of the program. Now over to you, Elavanil, for the day's program. Yes.
Dr. Sasikala is starting, sir. Dr. Sasikala.
Thank you, sir. Thank you, sir. Next, we move on to the program. Good evening to all. Welcome to Ask Your Mentor program, session 3, organized by Tamil Nadu AOMSI. Today's topics are local anesthesia, general anesthesia, and sedation. Mentors for these sessions are Dr. Shruti Rao for local anesthesia and Dr. Himarani for general anesthesia and sedation. The moderator for the session is Dr. James Anthony Bhagat. Dr. James Anthony Bhagat is an associate professor of Department of Oral Maxillofacial Surgery, Adiparashakti Dental College and Hospital. He had graduated and did his master's from Savita Dental College. His field of interest are maxillofacial trauma, orthognathic surgery, and clinical innovation. He has obtained copyrights for 2 procedures, currently working on certain innovative projects, and have indigenously designed a new plate for mandibular fractures. May I now request Dr. James Bhagat to introduce the mentors and start the program.
Just give me a minute, please. Dr. KK Raja is back. Actually, There was some technical issue. I was not able to unmute and not able to start his video. Sir, sorry for the inconvenience. Over to you, sir. Sir. Sir.
Dr. James, should we begin? Are we waiting for ma'am? We're waiting for madam.
Sir said, KK sir will speak. Should we start the program? Dr. James? You're muted, James. You're muted. James, you're muted. May I now request KK sir say a few words about the program, sir, for the students.
Yeah, please proceed. Yeah. Yeah, please proceed. Dr. Sasikala, you can proceed.
Yes, sir. Yes, sir. So James is an unmute. Muted. Cannot unmute himself.
Yes. Am I audible now? No?
Yes, yes.
Yes. Okay. So we'll start with the session for today. The first topic for discussion would be on local anesthetics. The mentor for today is Dr. Shruti Rao. She has completed BDS, MDS, and fellow of Indian Board of Oral Maxillofacial Surgery. She is currently the associate professor in Rungta College of Dental Sciences and Research, Chhattisgarh, and also consultant maxillofacial surgeon at VY Institute of Medical Sciences, Raipur. She received the prestigious JRD Tata Scholarship during her undergraduation MDS maxillofacial surgery from KLE Belgaum. She has completed a professional diploma in clinical research. She holds a fellowship from the Indian Board of Oral Maxillofacial Surgery. She was the first senior resident at AIMS Department of Trauma and Emergency. She was also trained in oral oncology from Tata Memorial Hospitals, Mumbai, Jain Cancer Hospital, Bhopal, and Regional Cancer Center at Raipur. She has done so many national and international presentations. A field of interest is maxillofacial trauma, cleft, orthognathic surgery, distraction, and oral oncology. So very good to have you here, ma'am. So we can start with the session for today. You can share the screen and we can start.
Thank you, Dr. James. It's a pleasure to be here with you all. And firstly, I'd like to humbly thank the Association of Tamil Nadu and Pondicherry for inviting me to this session. Thank you very much for providing me this platform, and I hope I can do justice to the postgraduates who are here today. Hi, I'm Dr. Shruti Rao. Let's keep this quite informal, and let's hope we all have a learning experience.
The local anesthesia, although used by the maxillofacial surgeon day in and day out, still we have certain important questions and doubts about the choice of local anesthetics and the basic mechanism, principle, and also the chemical composition, which is very tough at times. And the exam point of view and Viva point of view, it's slightly tricky for the students as well. So the first question to start with today is the pKa value and local anesthesia time for the pulpal infiltration. The correlation between the pKa value of a particular local anesthetic drug and the time taken, the onset of action, and regarding the pulpal anesthesia. Please share your thoughts. And
Sure, thank you so much. And I totally agree with you that probably it is the most, we read local anesthesia so much, but how much ever you delve into the topic, you realize, oh, there is something else, something new I learned. Each time I read the books, I discover something new. And I'm glad that, I'm probably looking towards a more of experience here. So let me take you forward. So what is this pKa value? It is a dissociation constant, and it's a measure of the affinity of a molecule for hydrogen ions. So you have the local anesthetic drug exists in its base form and ionized form, right? So when the pH of a solution has the same value as the pKa, you have equal quantity of the base form as well as the cationic form. And this is derived from something which is known as the Henderson-Hasselbalch equation. Let's get a little bit more information about this. Let's understand that there is a specific dissociation constant for each local anesthetic agent, a few of which are visible to us in this small table which is here. So why is this important? Basically, we need to understand that the free base form is what is significant in passing through the nerve sheath. Okay, so for a local anesthetic agent to enter into a nerve, into the exoplasm, you need its base form or the free form. And then once it enters in again to the cationic form, and the cationic form eventually goes and binds with the sodium channel, resulting in conduction blockade. This happens during this, in turn, prevents the depolarization of the membrane, and thereby it blocks further conduction. Now, what is this relation of this with pulpal infiltration? we need to understand that inflammation and infection are going to alter the tissue pH, right? And once they alter the tissue pH, obviously your extracellular fluid pH changes. This balance between the base and the cationic form change, and hence the number of free base form available to diffuse into the membrane are also changing. So here there is this study by Nico Fire et al., which established that the pus has a pH which ranges between 6 and 7.3. And Brown again demonstrated that when you have inflammatory exudates, they act by reducing the threshold of the nerve conduction, thereby increasing the pain, allowing the pain to pass more easily. And they also inhibit the local anesthetic. Also, you have a greater amount of blood supply, you have exudates. So the removal of anesthetic agent from a certain location is also greater. The action, by defaulting of local anesthetic agent. So how do we overcome this in an increased pH situation? One can go away from the area there is an acidic environment. How do we do this? Suppose I'm talking about, in this case, I'm talking about pulpal infiltration in a tooth which has a... What happens here? Intraperiosteal infiltration, can go above it and give a regional block. Once I do that, my possibility of a regional block acting is going to be greater, because in that region, there is a lesser amount of acidity. Going one step further, we can perform a nerve block, right? So a nerve block for a specific tooth will definitely not have as much, acidic environment in the region of the nerve block compared to the site of, that is the tooth in question. Okay, how else can we counter this? One can use a buffered local anesthesia. So this again was experimented, and in some preliminary studies, they noticed that in 71% patients receiving buffered local anesthetic agent, they received successful pulpal anesthesia within 2 minutes versus 6 minutes 37 seconds for unbuffered local anesthetic agent. Okay, so this again will answer the question of what is the time taken for pulpal infiltration. So in a routine pulpal infection, using a regular local anesthetic agent would give us anesthesia in about 6 minutes, 6 to 7 minutes. Whereas if we chose to use a buffering agent by adding 1 ml of 0.4% bicarbonate directly into the local anesthetic cartridge, this can be done as a chairside procedure, and this definitely increases the permeability of the local anesthetic agent into the acidic environment by leaps and bounds. So I hope I have brought you to the answer about what is a pK value and how it affects the time for pulpal infiltration, okay, and how we can speed up the process by the use of a buffered local anesthetic agent. These are a few references which postgraduates can go through and thereby achieve some more information about the same. Is there something that I have left unanswered, Dr. James? Is there something else that you would like me to say?
Yes. In a nutshell, the final word. Any LA with PK with lesser PK value has an increased onset of action, right? Is that so?
Yes.
So, yes. Certain times when we are giving LA, especially like a very mobile teeth with a very periapical granulation tissue.
Correct.
That is when it becomes challenging, because it's like the patient comes, it's a mobile teeth, Dr. I can only remove the
They
tooth.
expect you to just knock it off.
Yes, that happens. And particularly for those patients, even after giving a block, the block works well, but the tooth is it's not acting on the tooth. So we rely on certain other giving a PDL ligament injection. Sometimes it also lets us down, like as a maxillofacial surgeon, and then when extracting it becomes tough. So in those, any suggestions from your side in those. Will you directly go in for an accessory PDL ligament injection, or how is it?
Okay. So basically, I also found that, we have a greater concentration of local anesthetic agent in our topical sprays. So we could use a topical spray as a supplement to a local anesthetic agent in the local area. Another thing is that, yeah, of course, PDL injections are great.
Yes. Yes. Okay.
And so much inflammation will remain a challenge. I think regional blocks, maybe, regional block, might answer the question. What do you have to say to that, doctor? What, in your experience, will
Yes, but sometimes what I would do is maybe I have
ice
an
application?
articane. Yes, a different combination of LD. Maybe if you're
Right.
using lignocaine, maybe you can go with the articane or bupivacaine. Again, bupivacaine has a very
Has a
lesser
higher pH.
PK.
So I noticed I routinely use the chairside buffering, and I noticed that these are definitely,
It
they
helps.
they provide promise in this sort of situation.
Yes.
And apart from that, I also use some ice application, which helps in the situation. I think it's a good
Sure. Yes.
event.
Yes.
Yeah.
Yes. Thank you. So we'll move on to the next question. Okay.
Right.
How much of LA comes out with a puff of an LA spray? I think one of the common Viva question, maybe a tricky Viva question for the students.
Right. So basically, we have two versions of the spray available. One is that the Numbit, which is commonly seen in our OPDs. Yeah. So Numbit is a pressurized spray, which is in a pressurized can, you have 100 ml. And that is a higher concentration. It is a 15% preparation against the xylocaine or LOX spray, which is a 10% preparation. So both these have different amount of local anesthetic delivered with each actuation. The 5 milligram per xylocaine spray delivers 10 milligram per meter dose. However, it is important to, take 30 seconds between two sprays to be cautious, especially in the pediatric population while administering the sprays, because there is a very high risk of, toxicity if we are careless while applying these sprays. This is an interesting article I'd like to share in this context, in the context of the spray, that apparently the local anesthetic spray exhibits some bactericidal effects as well against E. coli and sanguinis and salivarius. And this was reported when, around 1 to 3 minutes from the time of application of the spray. It was something surprising that I came across. And I said, maybe it is worth sharing, because why not, if it would add benefit, then definitely it's a great idea to use a spray before injecting any patient. I think it has to be performed more routinely. We just, wait for the pediatric population or the more apprehensive patients and then pick up the spray. Why not use it in routine practice to make it comfortable to every patient before we, inject them? Some words of, some little care, by loading the injection in the blind side of the patient, spraying a topical spray before injecting. These are some things that I would encourage postgraduates to do so that your patient is more comfortable. Every patient wants, pain-free anesthesia. I know anesthesia itself is injecting and painful, but what if we can make it pain-free? We should do it. I think we should. What do you say, Dr. James? No? We should incorporate this.
Yes.
So
Yes.
Here again is one more study where they compared use of lignocaine gel versus the lignocaine spray prior to injection in a pediatric population. and they suggested that the spray is more effective. In my opinion, I think maybe the spray is more effective because the concentration is also more. In the sprays, we have 15% and 10% concentration, whereas in the gel it is 2%. So I'm not sure if the study is can be justified, but of course I would like to go through it in more detail before I make any such comment. But ultimately it comes down to this: maybe we should all use the spray prior to injection. So is there anything else that we
Yes.
should
Sometimes when we use the spray, the thing is, especially for giving an inferior alveolar nerve block, thing is sometimes the spray just trickles down the pharynx, and the patient might have a gag reflex following that, and certain times they feel it a bit tough. In that sense, would you prefer using a topical gel, or how is it? How do you prevent it? How do you
I think firstly, maybe we can keep our patients upright when we spray them.
Yes.
So that way, and your spray with the pressure of injection, some amount of local anesthetic will reach your targeted area.
Yes.
One concern with the spray is that, the tip needs to be kept hygienic. It needs to be kept aseptic.
Yes.
And a lot of people are tempted to just push it, touch the mucosa, then keep it aside and use it again in the next patient.
Yes.
I don't recommend that. I feel we should, sterilize it as per protocol and use it. At least put the tip in Sidex before we use it again, something like that. One thing is, maybe I'll recommend keeping the patient upright. Another thing is the topical gel. I think wherever we feel that, spray is not sustaining in its place, we can use a topical gel. And thirdly, instead of just resorting to our 25 or 26 or 27 gauge needles, we could use the cartridge with a 30 gauge needle, which is definitely going to reduce the pain of injection.
Yes. Sure. Okay. We'll move on to the next question.
Fine.
Reasons for failure of local anesthesia. I think already we slightly covered into this topic, especially in cases of an abscess or a hot pulp.
Right.
That's when the problem is a very excruciating pain. The patient wants extraction immediately. We give the block works, perfect block. But the thing is, when we try to keep the extraction forceps, patient jumps out of pain. So what are other reasons where the LA can fail?
So the typical description that you gave might be one of a spotty anesthesia, no? I think, where only the mantle fibers get anesthetized and the core remains unanesthetized, probably due to the inflammation, due to the infection, the environment that presents at the sites where we require the anesthetic the most. So what are reasons for failure? Let's look at it. One could have anatomical variations. Okay, so when we have multiple, like a bifid alveolar canal, that is going to compromise the action in inferior alveolar. Secondly, technical errors of administration could be a reason. A highly anxious patient. So many of our hot pulp patients who come to the clinic are people who haven't slept because of irreversible pulpitis. So the previous night they have spent awake in pain. These patients are going to have much more anxiety, going to be, much more difficult to please or to anesthetize, to sort of deal with in the OPD. With this is coupled the inflammation and infection. And finally, those with defective solutions. I think there might be situations where people unknowingly or carelessly end up using expired local anesthetic, which does not act. Occasionally, you do have like one batch which is not as effective as the others, where you notice it and note down the batch number, contact the company. These things also do happen, but primarily we need to go through the other reasons. So coming on to individual local anesthetic techniques. So where in the supraperiosteal infiltration can we have a problem, a technical error? So what is in our control is that we make sure that our technique is correct. So in the supraperiosteal infiltration, you want to inject near the root apex or above the apex. So when you do that, along the length of the root, obviously amount of local anesthesia and hence it will. So how we, this is, where does your dental anatomy come into play in oral surgery or in dentistry in general? What we sit and carve things and, we make tooth carvings earlier in BDS. That is because we need to know the approximate length of each tooth so as to give a proper supraperiosteal infiltration. What about the PSA? In the PSA, we learn about, upwards, inwards, and backwards, 45 degrees to 3 planes, or performing the correct angulation to reach the targeted area where your PSA nerve is. So in case your needle is too lateral to this, in case it is not high enough, in case it is too far posterior, different, suppose your orientation of anatomy is not correct. You need to, all PGs, we need to keep this in our minds that every time we place an injection, we give an injection to a patient, you understand that each patient has a different anatomy, a different size. So this is where we learned about the structures, the build, yeah, how large is the skeleton. According to all of this, you need to adapt and understand where we have the greatest chance of blocking the nerve. Coming to the middle superior alveolar. So here again, when is this MSA coming into play? In those 28% where, your PSA does not work. So your mesiobuccal root of the first molar does not get anesthetized. So therein you need to give an MSA and give it above the apex of the second molar. So here again, we need to understand the height has to be correct. Okay. If in case you do not give it at the correct position, it will again act like an infiltration, just like an infiltration. Coming to the anterior superior alveolar. Many times, as students, they keep by hearting, okay, supraorbital rim, infraorbital rim, infraorbital canal. It's all like you're by hearting the landmarks and you're trying to give it. But somewhere along the line, we lose track of where is our local anesthetic targeted. It is targeted at the origin of the anterior superior alveolar nerve, which is about 7 to 8 millimeter prior to the exit of the infraorbital nerve from the skeleton. So unless this part is understood, unless the student can apply pressure, allow the LA to diffuse into the canal and thereby, block the ESA, many times they do have nice anesthesia of inferior palpebral, lateral nasal, superior labial, everything is anesthetized. And the tooth in question is nowhere in the picture. You don't have any anesthesia there. So here again, remember the techniques and perform them step by step. Whatever your standard textbooks say, we all have learned that only. It's just that we need to keep adapting it to our practice and do what is correct. Yes. So again, what about the greater palatine anesthetic? Where in this case can we not have anesthesia? Many times around the premolar regions, there is overlapping of supply from nasopalatine and greater palatine, and hence both these need to be adjusted according to the requirement. Coming to the anterior middle superior alveolar, one may need supplementary anesthesia for central and lateral incisors when we use the EMSA, because this does not target the central lateral regions. So we could use another additional dental injection in the proximity of these teeth, right? So coming to again the inflamed tissues, I think we have touched this. We probably are coming. We discuss it in further detail if we have time, if time permits. Okay. So in a nutshell, I think we need to ensure that before we blame the company for that poor anesthetic agent, before we blame the patient for infection, We need to ensure that our technique, what we have learned and what we are practicing is correct. We need to adapt the technique to suit the physical structure of the patient.
Yes. Any word about tachyphylaxis for local anesthetics? Where there is a repeatedly, when students repeatedly give LA at a very fast pace, what happens is the drug action is not into place. In the sense, they first give one cartridge and then they do not wait. There's a sufficient waiting time, especially based on the thickness of the nerve, or whether it's a block or whether it's whether the nerve is a very fine nerve. It is based on that. So what they do is repeat without waiting. Immediately they administer the next dose of it. So we need to be careful about the tachyphylaxis also.
Absolutely.
Then
I think that's what, initially everyone wants to think that, yeah, I have injected, I can pick up my forceps. So we need to get this out of our minds. You inject your local anesthetic, take a walk, sing a song, and come back after 2 minutes. What do you say? Does that work for you?
Yes, ma'am, definitely. Give some time. I think patient also will settle down.
Yes.
I think it starts to kick in within 1 to 2 minutes most of the time.
Yes.
Sometimes it gets delayed. As you said, ma'am, I'll ask the patient to wait outside in the waiting area for 5 to 10 minutes. Not a problem. Because one of the sentence also you had also mentioned that if the patient is anxious.
Yes.
Notice once or twice. When the patient is very anxious, they say that the block is not working.
Correct. Yeah.
And then we ask them to sit outside for some time. And then when they come back, they say it is all numb. And they will say that after extraction, it is all the more numb. So I think once their anxiousness is coming down, I think it has a small part to it.
Correct. So we all agree. I think we need to give it time to act. Follow the standard protocol. Check for subjective symptoms. If it is an apprehensive patient, they will usually not accept any subjective symptoms. So then you check for objective symptoms, right? So you check it objectively. Check on the contralateral side, check on the injected side, and assess before you place a periosteal elevator. Please check with the probe. Please ensure that there is adequate anesthesia before we start off, right? Yeah.
The next question. Local anesthetic consideration in patients with thyroid disorders, hypertensive patients, and cardiac patients. Your call on that.
Okay, so now you are putting me in an odd situation because madam is here and this is all, so I'm a little shy. Is Hima Rani madam here? So let me try. Okay, let's see where this goes. So here it is. Thyroid disease, basically this gland is under the influence of many hormones. That is the TSH or thyrotropin from pituitary, which is itself regulated by thyrotropin releasing hormone from the hypothalamus. And then you have the thyroid hormones stored as iodide-rich thyroid colloids, which is T4 or thyroxine, tetraiodothione, which is got a half-life about a week. And that gets converted to the active form, that is the T3 or triiodothyronine, right? Which lasts for about a day. So these hormones give feedback and regulate the TSH release. So what do? They regulate protein synthesis via the effect on gene transcription. And they have profound effects on sensitivity of tissues to catecholamines, which is where we are of a major concern. What is the catecholamine that we are going to use routinely? It is epinephrine, which is used with local anesthetic agent, right? So here again, we need to understand that any patient who comes with a history of thyroid disease, many of them don't disclose it and they feel it's not of relevance to the dental setting. So unless you specifically ask them, do you eat some small tablet in the morning? Then they say, yeah, I eat L-Troxin 25 microgram, and then they look at you as if to say, why are you asking me this? I've been eating this for 25 years now. right? But that is of significance to you and me. And why is it of significance? Let's figure out. So in all such patients who have hypothyroidism, how do we commonly understand just looking at them? We need to see the appearance is very classical. They usually have, some amount of hair loss. They'll be lethargic, some puffiness, some eyebrow thinning. Usually these people have some amount of weight gain, and they'll complain of clammy extremities, cold, clammy hands, and some pretrivial edema, right? So decreased appetite. I don't feel hungry. I feel cold. Yeah, cold sensitivity. These are some typical features of hypothyroidism. So where is this concerned? What is our concern in the dental setup? Firstly, the main problem here is not about using local anesthetic as such, but it would be the worry of using opioid analgesics, using diazepam or midazolam in our practice. Yeah, and conscious sedation can be done with the help of nitrous oxide and oxygen, but diazepam and midazolam, if used, can precipitate a coma in these patients. We should be careful while using povidone iodine, which we routinely use to paint our patients. But as far as lignocaine as such is concerned, I don't think lignocaine adrenaline by far is contraindicated in these patients, and it does give a fair amount of anesthesia. However, these patients exhibit some amount of hypersensitivity, or not exactly called hypersensitivity, but we have to be cautious while using epinephrine in patients with hyperthyroidism, right? So a patient who has come to us saying, yeah, I am a thyroid patient, but I haven't been eating my thyroxine. When was your last checkup? Have you taken T3, T4 and TSH recently? So these are some things that we have to cross check. Why? Because in hyperthyroidism, your patient can be anxious. They can, get irritable and can faint on the dental chair. So adrenaline can exacerbate sympathetic overreactivity. Yeah. But this again, according to some schools, they say, no, this is just theoretical. It is not a real thing. So in such patients, some drugs given to in hyperthyroidism, like carbamazole, it can cause problems as far as your thyrotoxicosis and these things are concerned. Maybe we can ask Madden more in detail. Yeah, but there again, we need to be careful about using iodine. Now, how do we recognize who are these people who have hyperthyroidism? They might have exophthalmos, the classical bulging eyes that you see in hyperthyroidism. They could be anxious. These patients usually have, you know, heat intolerance. They might have a slight tremor. They can exhibit with a thyroid gland swelling. Okay, so all these are some typical features, and maybe a sudden weight loss and drastic weight loss. These are some typical features of hyperthyroidism. In such patients, it would be wise to ensure that we are cautious in the use of local anesthetic with adrenaline. Yeah. So coming to your next question, if I may move on, do you think I can move on?
So, lignocaine perspective, for a hyperthyroid patient, lignocaine with adrenaline, it definitely needs to be avoided if the patient is
yes.
in the
I
acute
believe
phase.
so.
Acute phase.
Yes, I believe so.
Yes.
And also those on carbamazole, we can watch out for any drug interactions. So in such situations, I think it would be wise to get a physician's opinion prior to use of any drug.
Yes.
Right. So coming to hypertension. So what is hypertension? This blood pressure is a product of cardiac output and peripheral resistance. How much how much blood your heart is able to pump, and what is the resistance offered by your vasculature, that is your blood vessels. So these two are dependent on multiple things. They are dependent on the heart, on the vasculature, on your autonomic nervous system, on your endocrine system, as well as your kidneys. Now, hypertension is a persistently raised BP. And the American Heart Association has given some basic guidelines for calling a person a hypertensive. So how many, you need to record BP for 7 days at a stretch if you are doing a home BP monitoring, right? They have strictly made the classification as to what is pre-hypertension, what is the hypertension stage based on the BP, the systolic and the diastolic BP, as well as the ASA grade of 1, 2, 3, and 4. Right. So what is of importance to us in patients who have a BP of less than 140 and less than 90? I think we can go ahead with our routine dental care. If our patient's systolic BP is going closer to closer to 160, diastolic is touching 100, I think it's wiser to recheck BP before we start routine care. Usually we could schedule their appointments in the late morning, because in the endogenous adrenaline peaks in the early morning hours. So any adverse cardiac events are more likely in the early morning. So these patients are better treated, in the later morning. And maybe keep short, less stressful appointments for patients who have a raised blood pressure. So in patients who have greater blood pressure, so this is what the American Society of Anesthesiologists has said about dental treatment in hypertensive patients. So an ASA grade 3 patient who has a BP closing approximating 180 and a diastolic pressure touching 110, better to take medical advice, restrict the use of adrenaline, try to use only plain lignocaine. But in routine practice, if you notice, and there are multiple papers to support it as well, that endogenous secretion of epinephrine as well as the injection of epinephrine, all of these are safe in the safely tolerated doses, right? So we don't have to worry about, oh, the patient is hypertensive, unless the patient has a systolic pressure which is more than 200, diastolic pressure more than 115. Then yeah, maybe wiser not to do anything. Forget about using local lignocaine without adrenaline. I think in such pressures, it would be wiser to medicate the patient, postpone your appointment, get the BP under control, and then proceed with whatever is planned. Yes. So gingival retraction cords, I think that needs to be used with caution, because they are usually adrenaline soaked, and we should use them with caution. And in patients, if at all we plan for a conscious sedation in such patients who are hypertensive, especially our patients in whom we are placing implants, usually fall into the little older age group. So in such cases, I think it would be wise to carry out a continuous BP monitoring, right? So another thing that we should be careful about is a postural hypotension, which is common with a few groups of drugs. So shall we move on to the cardiac patient?
Yes,
I hope
yes,
I'm not
yes,
taking too much time.
yes, slightly running short of time.
Oh, okay, okay. So I'm going to run now. Yes, I'm going to run. So we've said on your mark, get set, and now I say go. Right. So what about these cardiac patients? Firstly, many times I keep talking to my PGs and telling them about this, UGs as well. And we talk about A to L to assess the medical, conditions. Have you heard of this, sir? Dr. James?
Yeah, A to L.
No, you don't. Okay. So this may be in another session. So there we have cardiovascular and respiratory as C. It forms C. So primarily, why is it that we go and then again at H, we have hospitalization, history of hospitalization. Because when we ask our patients, do you have any cardiac problem? No. Do you have this problem? No. Do you have that problem? No. They say no to everything. And when you ask them, have you been hospitalized lately? They'll say, yes, yes. I had a heart attack and one stent was placed, and this was done 2 months ago, but now I'm fit and fine and I'm going walking. So, just to to wake up my postgraduates who are probably sleeping by now. Please don't sleep. It's only 8:50. Yeah. And it's wise to make sure that you don't have a patient who had an MI which was less than 3 months ago. Okay. So who are your very high risk, your medium risk, and your low risk? This is a beautiful table showing the predictors of cardiac risk. Yes. And let's move on quickly so that we have enough time. Again, let's reiterate the fact that in patients who have a recent history of MI, I think it would be wise to ask them to keep their GTN tablets, their isosorbide dinitrate tablets handy before you start before you start a dental procedure. Secondly, schedule shorter appointments. Okay, counsel them well so that they are not apprehensive. Take as many precautions as you can to keep the appointment peaceful and easy for the patient. Yeah, don't put an additional stress by shouting at your patient. Yes. And secondly, it would be wise not to take more than 2 carpules of LA with adrenaline. Okay, when it is 1:80,000 adrenaline. And in case your patient presents with a chest pain, do make sure that you summon the emergency management immediately. Yes. So keep oxygen in handy, be prepared, make sure you have taken your cardiologist's consent. Okay. If they have had an MI less than 3 months ago, please perform any dental procedure only in a hospital setup. Do not take chances in a small dental clinic. Yes. That is my word of advice. Yeah. And another thing is that many of these patients are on aspirin or clopidogrel cover. Yeah, they are on some antiplatelet aggregating drugs. So in such patients, we don't usually discontinue it by default. We do an INR, assess the current INR, and thereafter, if clopidogrel is there, we shift to aspirin and then perform the extractions or whatever. Coming to LA, make sure you do aspirate every time you use local anesthetic agent. You do not want to be injecting local anesthetic with adrenaline into a blood vessel. That can be quite dangerous to do. Yes. So that is what I have to say about cardiac conditions. And this is a beautiful textbook called Scully's Medical Problems in Dentistry, which I recommend each of you to go through. Yes, this is for the postgraduates primarily. So should we move on? And
yes,
because of shortage of time?
Yes.
Yeah.
Unnecessary considerations for patients who are allergic to lignocaine. Your quick words.
Yes.
I think yes.
Yes, only 1 minute, right? So basically, these patients whom we say are, many of your patients will come to you in a larger setup, in a college setup, saying, I went for an extraction, and thereafter, after I underwent the extraction, I had a swollen face, I had swollen fingers, they've had some sort of a hypersensitivity reaction. Firstly, we need to rule out whether this hypersensitivity reaction is an allergy to the methyl paraben, to the preservatives, or is it due to the allergy to lignocaine itself. So in case a patient is allergic to an amide local anesthetic, we should use and shift to an ester anesthetic. Your histamine blockers are good supplements to local anesthesia. We can use 1% diphenhydramine hydrochloride. In cases, like I will show you one article in which in a unit where I worked, they had a case where a patient was allergic to diphenhydramine hydrochloride. So in such a case, yes, we need to resort to general anesthesia. And of course, we can resort to hypnosis or acupuncture as well. These are alternative techniques to pain control. So this is one interesting article where articaine, and more recently developed local anesthetic agent, is actually a combination of an ester and an amide. And they compared the sensitivity to articaine in a patient allergic to lignocaine, and realized that articaine could be used safely. And this has been reported in more than one article. So I think articaine can be a good option. And here, this is the report which I mentioned, where a patient had allergy to anti-allergens. The patient was allergic to diphenhydramine and hence was taken up under general anesthesia. Right.
Yes.
Did that answer, did that more or less take care of what the question was, sir?
Yes, yes.
Is there anything else that we should ask the PGs should?
I think they also should be aware of the test dose for local anesthetics. And also recently, they're also discussing about the challenge dose, where it can be given intra-orally, maybe 0.2 to 0.3 ml intra-orally to the buccal mucosa, and check for any reactions other than the standard
instead
skin.
Of the intradermal.
Yes, intradermal injections. Okay. So that they should be aware of the challenge test dose. Yes. So this predominantly happens, even though if the question is like in the past history, whether they underwent extraction in the last time without any events, because whenever they are exposed to the first allergen, I think that is again we need to be cautious. That is not if they say it is uneventful, that doesn't mean that they will not be allergic to the ending.
Absolutely.
We always need to be cautious.
Sensitizing, yes. They might have just been sensitized to the allergen.
Yes.
So,
okay. One last question, significance of accessory innovation. I think we
discussed
about that. We
sort of touched upon it. I think the main cause of accessory innovation, or the main concern, would be the mandibular molars, where in case they do not get anesthetized, we do know that the mylohyoid nerve does supply some posterior teeth. So how do we get over this? You can give a Gauss-Gates block where the whole mandibular nerve is blocked. No? So therein your mylohyoid branch also gets blocked. One can use the PDL or intraosseous injections. They are a great support to any problem like this. And of course the mylohyoid nerve block, which can be given near the mylohyoid ridge on the lingual aspect of the second molar or the posterior most tooth in question, right? So in case we notice that there is a bifid inferior alveolar canal on the radiograph, we can deposit another separate volume of solution inferior to the normal anatomic landmark. And many times you have cross innervation, especially in the anterior region, in the region where the ESC and the MSA overlap, or the PSC ESC overlap. So in such cases of cross innervation too, we could either use supraperiosteal infiltration, or we can use the PDL injections, right? This is something interesting, that in pediatric dentistry, often it is noticed that for endodontic treatment, they do not manage to anesthetize the molars using a PSA. And why does that happen? It's because of the flaring of the roots. Many times your palatal supply only supplies the nerve, the tooth itself. So in such cases, they require an additional palatal anesthesia for tooth anesthesia. Sir, we're not able to hear you, sir.
Yes. The choice of anesthesia in the infected region.
I think we have touched this adequately.
Yes. Yes.
So let's not
buffered
go back into it. Yeah,
buffered,
buffered local anesthetic. Yeah, and those studies which I mentioned, I think you all can go through it in detail. Yes.
Sure.
Right.
How to diagnose and treat systemic toxicity?
Okay. This again is a challenge to talk in front of Madam, who is an anesthesiologist, senior practicing anesthesiologist. But yes, let's understand that our local anesthetic, especially the one that we standardly use, that is lignocaine, is a very sweet drug. In initial doses, it is used, it has therapeutic usages in both the CNS as well as the CVS. In the CNS, it is used as an anti-epileptic, it has anti-epileptic doses, and in the cardiovascular system, it can be used as an anti-arrhythmic drug. So then we need to understand what is this threshold. So basically, you have an anticonvulsant level that is 0.5 to 4 microgram per ml. Pre-seizure signs and symptoms are seen at 4.5 to 7 microgram per ml, and tonic-clonic seizures are seen beyond 7.5 microgram per ml. So because do we have 2 minutes? Do we have 2 minutes?
We are slightly already overshooting on
We're
time.
overshooting.
Yes,
Okay.
yes, yes.
So I'll quickly just touch upon it.
Yes.
So just like I said, the first and the most permeable to local anesthetic is your CNS. Yeah. So in case your initial injection shows that your patient is sort of drowsy or is hyperexcited, you need to take one step back and analyze, is your patient going, a hyper responder to your local anesthetic agent, and play with caution. Do not be very generous in injecting such a patient. Secondly, in your patient, CVS effects are not so sudden or drastic. Usually you can only see a mild, unless you totally go overdose, you will not cause any major problem. Something that we commonly notice is its effect on the skeletal muscles, which is seen in some cases, and it is reversed within 2 weeks. And coming to the respiratory system, only at overdose levels you can produce respiratory arrest. So what is this elevated blood level of LA? It can occur because of 4 major reasons. Because the biotransformation of the drug is unusually slow, because the unbiotransformed drug is too slowly eliminated, because too much of a large dose is injected, because of rapid intravascular passage. Okay, so there are multiple reasons why this could happen. What we need to pay attention is that we need to observe and be conscious that we pick up the CNS and CVS signs earlier on, okay, so that we can control the situation, okay, or support our patient. You usually would see them get some minor tremors, become a little dull, stop responding normally. Yeah, not always go into syncope, but you will see these symptoms. You'll see them showing these symptoms, and at that point, I think we need to be careful. And if at all you've given enough LE, unfortunately not at all been careful, and your patient has resulted in a severe adverse, a severe toxicity, and gone into generalized tonic-clonic seizures or had a cardiac event, please start BLS, call for the ambulance, and don't be too brave. Please reach your patient to a better medical facility to be managed. Yeah, I think I've more or less touched it. All of this is beautifully given in Malamed. Yeah, beautifully. The toxicity reactions and how we should deal with them. Yeah, so these are some of the references that I would like to share with you. And thank you very much for giving me this opportunity. I'm most happy to take questions. So I am here for you, PGs, in case anybody wants to type out questions. Dr. James, please reach them to me, and immediately before the end of this session, we will reach them their answers.
Sure. Thank you, ma'am. You had briefly explained about
Dr. James.
Yes,
Dr. James and ma'am, the questions can be typed in the chat box, but the answers will be sent through email because we don't have enough time. So we'll compile all the questions and answer them together through the email. So,
that'll be great. That'll be great. Yeah.
Yes. Thank you.
Thank you.
Thank you, Dr. Shruti, ma'am. It was good discussing all these questions. So hopefully postgraduates would have taken a few take-home messages from the talk which you had given. Thank you very much once again.
Thank you. Pleasure.
Yes. Next mentor would be Dr. Himarani, ma'am. One of the most experienced anesthetists, almost 35 years of experience as an anesthetist. It's very happy to introduce you, ma'am. Thank you for being with us today. Yes, a quick word about ma'am's career. Ma'am has completed undergraduation MBBS from famous Stanley Medical College. She has completed a diploma in anesthesiology from Madras Medical College. Almost, as I told you, 35 years of practice in anesthesia. Ma'am is specially trained in anticipated difficult airway situations, trained in fiber optic bronchoscope, trained in submental blind nasal intubation and retrograde intubation, trained to give anesthesia for cleft chili. I think she's the right person to be talking to us, because not many anesthetists are exposed to maxillofacial surgery. Very few anesthetists are interested in this field because it deals with compromised airway situation. It is one of the challenging phase. And the next problem with the anesthetist is for the ease of having a nasal intubation. So it is a specialization which has to be more pertaining to maxillofacial surgery. So we are happy to have you here, ma'am, who's more specialized in maxillofacial anesthesiology. Welcome. Please, you can share the screen. We can start with your class.
One second, ma'am. Vijay, வா ஷேர் பண்ணு வா. Shall we start?
Yes, we can start.
Thank you for inviting me for this program. I think it will be useful for PGs, especially MBS PG. Today I'm going to talk about, first question is about laryngeal mask airway. It is a supraglottic airway device used to maintain the upper airway, especially during anesthesia. It is invented by Dr. Archie Brain and is a good alternative for bag mask ventilation. Because if you do bag mask ventilation, patient will be inhaling more of oxygen or whatever anesthetic gas will go into the gastric system, and then there will be gastric distension. To avoid it is better for supraglottic airway to maintain any airway during anesthesia. And then LMA is very much used in the emergency situation where you can situations such as cannot intubate and cannot ventilate. What are the indications? We'll see about where we can use this LMA. Usually it is used in the operating theater in a day, usually in a daycare surgery, that too in selected cases, not for every patient. The surgery should be less than 2 hours. It also aids in the tracheal intubation, and it is also used in the ICU, intensive care unit, emergency situation, in remote places. Even nurses can intubate, insert this supraglottic LMA in the unconscious patient, and also in the failed intubation. Failure to intubate a patient in that situation also, we can use LMA in emergency situation. Another is there is a special LMA which is designed to insert FOB, fiber optic bronchoscope, and also it can be used. We can use it in the procedure of blind nasal intubation, and that is also used in the professional singers, so that we may not be injuring vocal cord like that. Then it is also useful in edentulous patients, so that we can fix the device. But it has got its own disadvantages. Though it covers the oral airway, so there will be a minimal amount of leak around the LMA. That too, if you increase the airway pressure above 20, there will be a minimal leak around the airway. So we cannot administer 100% or 100% anesthetic gases into the patient. Sometimes the patient will have, due to the aspiration like that, laryngospasm and gastric aspiration. There will also be, in case of obese patient, there will be difficulty in proper positioning of the LMA. Then contraindication. We'll see about the contraindication. It is very difficult to insert the LMA in the upper wear restriction, that is abnormal anatomy. Difficult, there will be also difficulty in placing the LMA in obese patient, already I mentioned, and there will be increased hair leak. There will be because of this hair leak, there will be more chances of high risk aspiration. And also if it is in the patient who has got a micronathia, that is decreased pyramidal distance, but with a small mandible, it is very difficult to correctly position the LMA in a correct position. Then in the case of restricted mouth opening is also, because it's a bigger device, it cannot insert the LMA for these patients. And it also, because of this air leak, there will be a risk of hypoventilation, gastric insufflation, especially in the obese patients. Then types of LMA. There are more than 4 types or more than 5 types of LMA. That is, one is originally invented, that is the classic LMA. Second is pro-seal LMA with a drainage tube, so that we can aspirate any gastric aspiration like that, we can do it. It has got a concealed drainage tube along with this pro-seal LMA. And then next is fast-track LMA. Fast-track LMA is it is also designed to pass the FOB, that is fiber optic bronchoscope, and also the ordinary nasal ray, so that they can intubate in the case of difficult airway. And then there will be another is recently invented is drainage tube gel LMA, so that it can negotiate the the fiber optic bronchoscope or the nasal ray to intubate in case of emergency or difficult airway. LMA has got an elliptical flat mass with a stem at a 30 degree. The stem ends in the 15 millimeter connector. Yeah, and then this connector has got a universal connector that is 15 millimeter, which is connected to the breathing circuit so that we can ventilate the patient. It has also got an inflation tube, a pilot balloon, and then valve, and also grill bar across the mask, that is the patient end, to prevent the folding of epiglottis during insertion.
Ma'am, sorry to interrupt.
Yes, ma'am.
Please go to full screen, ma'am.
Full
Not
screen.
in full screen. Yes.
1 second. There is no screen is by the side of the screen. Slide 1 second.
Go to slideshow, otherwise.
Slideshow on. There is no option like that. It is obstructing our videos are obstruction. That's it. 1 second, no?
Okay.
Vijay. That's
Ma'am, can I share the screen, ma'am, for you? Will it be fine?
Ma'am, you are muted.
James,
Yes, ma'am.
could you please share the screen otherwise?
Yeah.
Ma'am is facing a problem.
Yes, ma'am, I'll do it.
Thank you.
Is it, ma'am, are you able to see the screen, ma'am?
Yes, perfect. Yeah, thank you very much.
Ma'am, Ma'am, you can. Imarani, ma'am, are you able to see the screen, ma'am? I think ma'am has some network issues. Just sorry for the interruption. She'll just join us shortly.
James, are you muted?
Sir? No, sir. It's just waiting for ma'am. Hello. Sir? Okay. So till ma'am joins us, we'll quickly review about the LMA. LMA, the laryngeal mask airway. It's in times of emergency, it's the go-to way of intubating the patient, as ma'am had discussed. There are certain disadvantages with an LMA. We cannot use an LMA as a main endotracheal tube. It is not so. In times of emergency, where we are not able to place the endotracheal tube, for example, a retrognathic retrognathic mandible. Sorry, in those situations, LMA will come into play. Especially certain indications where ma'am had discussed about not using an LMA in a singer, where we need to be additionally careful about the vocal cords. So in these patients, LMA comes into play. Again, LMA, we can use it only for a limited period of time because of the gastric regurgitation which can happen from an LMA. And also, all the anesthetic drug cannot be delivered directly into the trachea because it is placed superiorly and it is not placed. Yes, yes, ma'am. Yes. Yes.
1 second. Huh?
Yes.
Now I am audible.
Yes, ma'am. You're audible.
Okay. Shall I proceed?
Yes, ma'am. Please. Yes. Ma'am.
So I finished class. Okay.
Yes.
Next, this is procedure diagram of it and also intubating LMA. Next slide, please, sir.
Yes.
Yeah, LMA is how to place the LMA. LMA is first placed on the flat surface. Cuff is deflated completely to avoid folding by applying, and also by applying, then we have to apply the water soluble gel over the both sides. The patient should be well anesthetized, or you can use it in the unconscious patient without any gag reflex. LMA is passed behind the tongue with backward pressure against the hot pellet using our index finger, and then with your other hand, you have to push the LMA till the slight resistance is felt. Cuff is inflated, then the cuff of the LMA is inflated with air, and then the insertion, whether we have put the place the LMA in position, we have to check with the auscultation by auscultation for bilateral equal air entry and SpO2 saturation, and also capnography. You have to confirm the position of the correct position of the LMA in the patient. Next slide, sir. Next slide. What are complications? Most common complication is aspiration, gastric aspiration. Already I mentioned there will be a minimal amount of leak around the LMA. So as gastric aspiration is very common with the LMA. That's why we have to use the patient in the selected patients only, that too in the daycare surgery. And it can be usually used in case of emergency. There is nowhere to go. We have to intubate the patient in the case of emergency, and also during the cardiac arrest because of the aspiration, and then because of the improper position of the LMA, there will be hypoxia due to the less passage of the anesthetic gases, especially oxygen, to be delivered to the patient. Then also due to the folding of LMA, also there won't be contact between the oxygen to the airway. And also injury, there will be, because of a large size and the improper positioning of the LMA, there will be injury to the oral cavity, especially pharynx, and there will be bleeding, and then it will also compromise the airway. Next, sir. So size, there are size from 1, 1.5, 2, 3, 4, and 5. In case of neonates, up to 5 kg, we can use the size 1 LMA. In that, we have to inflate the cuff volume with a 4 ml. Then second is 1.5, that is infants, 5 to 10 kg. We have to inflate the cuff 7 ml. In case of children 10 to 20 kg, the size used is 2 kg, 2 size LMA, and then the cuff inflated is 10 ml. In case of the normal adults, that is below 40, for below 50 kg, that is 20 to 30 kg, 50, 40 kg, 45, 49 kg, you can use the size 3 LMA. You have to inflate 20 ml air into the cuff. And then in case of a patient 50 to 70 kg, we can use the size LMA size 4, and then volume into air inflated is 30 ml. In case of obese patients, more than 70 to 70 kg, that is 70 to 100 kg, we have to use LMA of size 5, and then the cuff inflated is 40 ml. Next. Then these are the LMA uses. Adult one, this is a pediatric one, that is 1.5 size. It has got a elliptical mass, that is the patient's end, and it has got a bars. And then this is a pediatric, and this is the inflating tube, the pilot, and the valve. This is the inflate, that is intubating LMA, it is angled, and then there is no bars. When compared to this, there is no bar. You can introduce the endotracheal tube, nasal ray through it, and intubate the patient in case of emergency. Next.
Yes. With the end of that, quick question. In case of a difficult airway, not able to put in the endotracheal tube, we have given the muscle relaxant, not able to succinyl choline, we're not able to intubate. Can we do take an LMA and then
that is what I'm telling.
yes,
Yeah.
yes.
In case of failure to intubate, even in case of failure to intubate, and also in failure to ventilate the patient to maintain the saturation, it is a wonderful LMA, that is one wonderful supraglottic device, so that it can maintain the saturation till the any fiber optic surgical tracheostomy can be done in worst condition. It is a boon for anesthetists.
Yes, ma'am. In that sense, till what time, if the patient is going in for a laryngospasm, when we are using an will they go in for a laryngospasm even when we are using an LMM?
Well, the patient, that's what I'm telling you. Patient should be fully anesthetized. When the patient is fully anesthetized, there is no chance of laryngospasm due to laryngoscopy. But
Yes.
due to other causes, because patient may be a bronchial asthmatic patient, or maybe a patient have got reason LRI, so that the lungs there will be hyperreactive, even for at least for 6 weeks after the LRI URI. So in that case, we cannot use, but we can use in case of emergency. Patient emergency means almost patient will be unconscious, and also we can give mild sedation and then we use the LMA in these patients.
Ma'am, in that sense, can we avoid using a tracheostomy? Can tracheostomy be avoided if we use an LMA?
Yeah.
It can be avoided.
To
Yes.
tackle the emergency situation, so that we can maintain the saturation, and then if you don't want to go to the hypoxic state.
Yes. Yes. Sure. The next question. Anesthetic consideration for a temporomandibular joint ankylosis patient. Your point of view.
Next. Usually, the usual choice for a TM joint ankylosis patient is fiber optic bronchoscope guided intubation, either without awake with the upper airway block, we can do the fiber optic bronchoscope, or without it, or with sedation also we can do the fiber optic bronchoscopy and intubate a patient. And then another method to intubate LME, the TM joint ankylosis, blind nasal intubation after giving upper airway block. And then the next is in the case of emergency or upper airway, any laryngeal tumor like that, upper airway pathology, we can use percutaneous dilatation tracheostomy and surgical tracheostomy in case of emergency. Selective is usually preferably fiber optic bronchoscope guided intubation. Otherwise, if it is not available, if they are not trained, we can try with the blind nasal. But in case of emergency and also in case of upper airway pathology, also we can try with percutaneous dilatation tracheostomy and surgical tracheostomy. Then how to prepare this? First, we have to assess the patient. Medically, any problems according to ASA classification, we have to assess the patient. Any of the comorbids is there, we have to assess and treat it, and then only we have to take the patient for TM joint ankylosis anesthesia. Then first we have to assess the airway. Already we all be knowing Alembic classification is grade 1. So there it is divided into 4 grades. Alembic classification to assess the airway. Now, first grade is soft palate, uvula, fauces, anterior posterior pillars are visible when you examine the oral examination. When you ask the patient to open his mouth and put out his tongue, we can able to see. If you are able to see the soft palate, uvula, fauces, anterior posterior pillars are visible, then it is grade 1, so that we can intubate normally. Then grade 2 is soft palate, fauces, and the uvula, partial uvula will be seen. The grade 3 only for soft palate, base of uvula are seen. And the grade 4 is hard palate alone or visible. So in the grade 2, 3, 4 are, we have to consider it as a difficult airway. FOB can be done, that is fiber optic bronchoscope guided intubation can be done both in the awake condition and also in the sedated patients. Usually, if you want to do the patient awake, but you have to give some sedation, mild sedation with the injection container like that. And then initially we have to block the upper airway with xylocaine jelly with the injection xylocaine locally. The two things you have to block, 2 nerves, that is superior laryngeal nerve. It is blocked by injecting 1% xylocaine at the corner of supraoid. So above the cord it will be anesthetized. Then second injection is recurrent laryngeal nerve block. It is blocked by injecting 4 ml of 4% xylocaine transrectally at the lower third of the brachiothyroid membrane. If you already asked a question, the patient will go for laryngospasm. If you don't anesthetize, if you don't block the upper airway, there are more than 95% of chances of patient going for laryngospasm and hypotension and bradycardia. Next slide, sir. This is the fiber optic bronchoscope. Advantages: it is useful in awake patients, and the patient will be on spontaneous respiration, and then spontaneous respiration is maintained. If you want to do it under sedation, so now we use the injection dextrometh. We can use the drug for conscious that are used to intubate a patient using the fiber optic bronchoscope. The disadvantages: it is sometimes some patients will be uncomfortable due to railroading of the endotracheal. So in the final stage, we have to pass the after viewing the trachea like the larynx, we have to railroad the endotracheal. That will be more uncomfortable for the patient because the patient is awake. And then due to this, the heart rate and BP will be raised. And under sedation, already told, sedation with injection dextrometh infusion again. You have to give a loading dose of dextromethorphan 1 microgram per kg weight. After that, maintenance is 0.4 to 0.7 micrograms per kg weight per hour. Advantage is more in this case compared to the patient doing when you do FOB under an awake patient. Here in the under sedation, patient will be comfortable, cooperative. There will be less increase in the heart rate and BP, especially in the hypertensive patient and also in the anxious patient. Disadvantages because sometimes if you're not able to intubate, or if you're taking more time to intubate through fiber FOB, there will be a respiratory depression, airway flux may be loose, there will be aspiration risk. The complication, other complications are sore throat, hoarseness of voice, hematoma, vocal cord injury, epistaxis due to the passage of nasal tube or a fiber optic tube through the nostrils, and then influenza, spreading the infection. Then sometimes the last complications, rare complications is subcutaneous emphysema and pneumomediastinum. And second method is blind nasal intubation. It is advantages. FOB, it can be used. If it is not, FOB is not available. It is very less expensive. Disadvantage, it has got disadvantages like it is uncertainty in intubating a patient. And there will be it's a blind procedure. We may injure the cricoarytenoid cartilage and the vocal cord and epiglottic damage also is more. And then if you want to do, if you are in blind nasal intubation, then we require more patience and gentleness needed to intubate a patient. And for any patient, even for awake patient or sedated patient, we have to keep the patient nil-oral for 6 hours. And then tablet pantoprazole 40 milligrams should be given previous night. Anticyclox like injection glycopyrrolate 0.2 milligram should be given 1 hour before surgery, IV intramuscularly. Then we have to start the IV fluids before the surgery, 1 hour before surgery. And then we have to, before starting the procedure, we have to administer oxygen through the nasal like or any port. And then we have to mild sedation like injection fentanyl 2 micrograms per kg weight should be given. And then already told you upper airway should be blocked. And then nasal spray with a vasoconstrictor like Nicotinamide and nasal drops can be given. Then procedure to be started. Can be started.
Yes. So the current trends is the fiber optic intubation. That is what we use. When do we give LA? Because you put in the fiber optic endoscope, and the LA has been administered through the bronchoscope. No?
First, we have to start the patient on IV fluids. When the patient is put in on the table, first we have to give them some sedation with injection fentanyl like that, or midazolam or anything you can give. That is to micro. Then the patient will be up. Then the anxiety will be reduced. Then we have to give the upper airway block with the superior laryngeal block, recurrent laryngeal block with the injection xylocaine locally. Then we have to apply nasal xylocaine jelly into both the nostrils. Then only we have to introduce the fiber optic bronchoscope through the nostril.
Yes. For the recurrent laryngeal nerve block, you usually use plain lignocaine, or is it with adrenaline?
Plain. For recurrent, for superior laryngeal nerve, we block with a 1% xylocaine without any vasoconstrictor like that, or any preservative.
Yes.
For rectal now, we are injecting 4% silicon, plain silicon.
Yes.
Both are plain only.
Yes. If the recurrent laryngeal nerve is being anesthetized for a longer duration, post-operatively, if the patient have problems with the aspiration, can that happen?
Usually, the procedure will take minimum half an hour to 1 hour. Lignocaine duration of action is minimum 1 hour. So, the dosage of that is activity of the drugs will vanish up by 1 hour. It should not exceed the dosage. In case of xylocaine, we have to we are using without plain. We are using without plain xylocaine only we are using.
Yes.
So, we have to, according to the dosage, 4 milligram per kg weight, according to the patient's weight, we have to calculate the maximum toxic dose. According to that, we have to give the upper airway block.
Sure. Thank you.
After 1 hour, you can inject xylocaine again.
Yes. So we need to better avoid longer acting local anesthetic drug in that perspective.
Usually, shorter xylocaine is preferable.
Yes.
There's also immediate fast action, onset of action is there.
Yes. Quickly, the next question: the types of endotracheal tubes and its indication.
Why do we use endotracheal? To deliver the anesthetic gases, including oxygen, into the trachea during anesthesia for ventilation. It is usually made up of polyvinyl chloride. It is ideal an endotracheal tube should be non-toxic, non-allergic, smooth, conductive, and cheap, and should be cheap also. Should be placed in the trachea, mid-tracheally, 4 centimeters below, above the carina. Endotracheal structure of the endotracheal tube. It has got a long tube with a bevel in the distal patient end, and under the machine end it is round. It is connected to the 15 millimeter universal connector to be attached to the breathing circuit to ventilate a patient during anesthesia. And then the patient's tip is bevel shape so that you can visualize the trachea, vocal cords, everything. It is useful for the shaping of the bevel tip of the endotracheal tube. The cuff it has also got a cuff with a pilot tube and valve. Low pressure high volume, it is 2 types. One is low pressure high volume cuff and high pressure low volume cuff. Usually we use low pressure high volume cuff, and also it has got at the distal end at the lateral side. It has got a Murphy's eye. See, if the tube gets blocked if it impinges on the tracheal wall, or it is blocked with a tracheal secretion, we can still ventilate the patient using the Murphy's eye, which is incorporated in the hello. Hello.
Ma'am, I just got disconnected. I'm just connecting it back.
Okay.
Yes.
Now it's okay.
Yes. Yes.
So with Murphy's eye, a small hole will be at the distal end of the endotracheal tube. Through that we can ventilate a patient for some time, so that we can avoid hypoxia during anesthesia. This is a protective mechanism incorporated in the endotracheal tube. Next. Sizes of endotracheal tube. Usually in adult male, use 8 to 5 for orotracheal intubation. Use 8 to 8.5 millimeter internal diameter. For female, it is 7 to 7.5. But for a nasotracheal tube, it is common. Usually we use 7 millimeter internal diameter nasotracheal tube. That is usually nasal ray used both for the male and female. And the cuff pressure inflated is 18 to 24 millimeter of mercury. Then in the pediatric age group, we have to calculate according to the gestational age group. That is, in case of preterm babies, you have to calculate the gestation age in weeks. It is divided by 10 plus 0.5 is the size of the endotracheal tube. For age below 6.5, it is age by 3 plus 3.5. Age above 6.5 years, it is age by 4 plus 4.5. And then when coming to the length of the tube, this orotracheal tube is age by 2. Age by 2, so almost up to 12 centimeter, age by 2 plus 12 centimeter calculation length, we can insert the orotracheal tube. For nasotracheal tube, it is age by 2 plus 14 centimeter. Some types of tubes. Oral endotracheal tube, that is both uncuffed and non-cuffed are available. Nasal ray tube is used for the maxillofacial surgeries and also ENT surgeries. And then oral ray tube is used for the cleft surgery. And then Oxford wood, it is more less chance of kinking. So it is used in the cleft surgery and spine surgery, especially in the prone position. And then latex, flexometallic tube, latex armor tube or flexometallic tube is used in the oral surgery and is used for submental intubation, head and neck surgery, spine surgery in prone position. So that there is no kinking, there will be a continuous flow of anesthetic gases to the patient. In the cold syringe is rarely used. Patient's end is usually is during the pediatric age group. Patient end is narrow with a smaller diameter, that is 2.5 to 4.5 centimeter. Patient end is larger with a wide diameter. These are types of oral endotracheal tube with a cuff. Next. This is oral ray. It has got a curvature so that it can be used in the cleft surgeries especially. This is nasotracheal tube. Most of it is used in the facial-maxillary surgeries and also ENT surgeries use it. Complications. Usually ventilator associated, because we are bypassing the nasal cavity. So that nasal cavity is a filter of any whatever air is patient is inhaling. We are bypassing that nasal cavity. Straightly we are introducing into the or trachea. So that ventilator associated pneumonia is very common in case of patient on continuous prolonged ventilation in the ICU. Then if the cuff is very defective, it will result in aspiration and due to the leakage of gastric section into the trachea. Because during intubation, there will be more chances of bleeding and infection, especially due to repeated attempts of intubation. And then the perforation of oropharynx during intubation. And also due to the prolonged or due to the insertion of endotracheal tube in the trachea, patient may develop hoarseness of voice due to vocal cord injury. And there also during the laryngoscopy and introducing the endotracheal tube, there will be more chances to the damage to the teeth, especially loose tooth and also to the lip. And then sometimes by mistake, if you introduce the endotracheal instead of into the trachea, if introduced into the esophageal replacement, there won't be any oxygenation to the patient. Patient end up in hypoxia leading to cardiac arrest.
Okay. Yes, ma'am, a quick word, because when we inflate the cuff, ma'am, what is the pressure exactly it has to be?
It should be 18 to 24 millimeters of water.
Yes, because we do not measure that. We have a small cuff and then we use a syringe.
Actually, 6 to 8 ml is normally for any normal weight adult. For in the pediatric, you have to be less, 2 to 4 ml.
Yes.
According to the age, we have to judge what is the type of tube we are using, what is the age and weight of the patient also, besides how much of cuff pressure we have to inflate.
Yes. But post-operative, usually the patient has some amount of pain in the throat. They complain about that.
Yeah,
how can that be avoided? Is it there's no way out?
No, we are using jelly also, but we are bypassing the nasal airway and we are passing through the epiglottis and then vocal cord. No, there will be a minimum. There will be some aberration in the tracheal walls. It will present with the hoarseness of voice. Some pain will be there.
Yes. Sure. About there was a paper about this keterol mouthwash, mouth rinse, whether they can hold it in the throat and then that gives some amount of relief. Do you advise that, ma'am, or it's not required? It's not required. Okay, sure. We'll go on to the next question. Post-operative management of patient with endotracheal tube in situ. So.
Usually, patient is monitored in the ICU with the patient with the endotracheal tube in situ. We have to monitor the vital signs. We have to give the feeding. Apart from them, bladder catheterization should be done. to monitor the urine output forwardly. Apart from the main care is tracheal, because patient is left with the endotracheal tube. Care includes endotracheal tube fixing. You have to fix the endotracheal properly, and we have to stabilize it. We have to, again, even if the patient is on endotracheal tube more than 24 hours, you have to adjust the position. We are assure the position of the endotracheal, whether it is in the correct place of trachea. And then also we have to monitor the cough pressure using the cough pressure monitor device is there. We have to attach the cough pressure device to the valve of the endotracheal tube, which will be lying outside the patient face. We can measure the cough pressure with that device, and then proper suctioning, sterile suction should be done. Endotracheal tube is fixed with using the medical adhesive type to avoid accidental extubation. Suddenly the patient will be extubated. Unexpected extubation can occur. So to minimize this, you have to properly fix the endotracheal tube using the medical adhesive tape like that. Then before applying the plaster, we have to clean the skin with an antiseptic solution and ensure the tape you are using, the plaster you are using around the patient's around the face should not be too tight or too loose to prevent skin ulceration. Because the patient is on prolonged intubation, the skin ulceration is very common to occur. So the tape we are using to fix the endotracheal tube should not be too tight or too loose. And then the tape is placed usually over the upper lip and encircled around the neck, but it should not impinge the circulation, not obstruct the circulation. Then oral airway. Usually oral secretion should be suctioned without adjusting the endotracheal tube during the patient is on endotracheal tube. And the endotracheal tube cough pressure is monitored every 4 hours. Positioning of the endotracheal tube is confirmed as per policy, like taking X-ray like that. There should be a separate cough pressure monitor for each patient. There will be, because to avoid the cross infection, endotracheal suctioning is done every first 1 hour, then the 3rd hour, 4th, 8th, and 12 hours. At least every 8 hours, at least we should suction sterile endotracheal suction should be done. Cough pressure is maintained. Cough pressure is maintained around 25 centimeter of water to avoid leak and tracheal aspiration. Maximum allowed is 30 centimeter water to avoid leakage and tracheal aspiration. And the physician, if the cough pressure exceeds more than 30, we have to suspect airway pressure, increased airway pressure. So we have to consult the intervention, the ICU physician or anesthetist. Cough pressure monitor is attached to the valve at the pilot balloon, which is incorporated in the endotracheal tube. In the case of the ICU, we have to do the suctioning. The patient will be on the ventilator. Once in some patients, even in the closed circuit, there will be a suction catheter placed mechanically in the ventilator, mechanically ventilated patient. This will avoid every time every 4 hours, 8 hours, keep on disconnecting the circuit and cleaning the oral suction during the tracheal suction. To avoid that, you can keep the inline suction catheter. And then other things, if the patient is conscious, the patient is with the TPs, with spontaneous respiration, we can do open suctioning. Suctioning pressure is usually around at least 140 to 180 millimeter of mercury. Suction should be done under strict aseptic precaution. Catheter is rinsed with every time with the normal saline after usage. Patient is before doing suction, we have to give 100% oxygen for 1 minute, and also after suctioning also we have to give 100% oxygen. Then if the tracheal secretion is very thick, we can inject or instill the 2 to 3 ml of normal saline into the trachea, so that we can dissolve the thick secretion and also blood clot. Catheter is usually the catheter used is passed till the tip of the endotracheal tube for at least 4 centimeter above the carina to avoid tracheal injury. Ensure there is no kinking of suction catheter during suctioning.
In cases where we decide upon leaving the tube in situ, sometimes we'll be using a flexible nasal ray tube. Yes, ma'am. If you are planning to have the endotracheal tube in situ, would you advise for change of the endotracheal tube as a metallic endotracheal tube, or how do you advise? Because we cannot retain the flexible tube for a longer time, right? Because the suction also is slightly difficult. Suctioning and maintaining the endotracheal tube is difficult with the flexible nasal ray.
Nasal ray is preferable. If it is more than 48 hours, we have to change the nasal ray tube. Otherwise, if the patient is more than 7 days like that, we have to do percutaneous tracheostomy.
So the choice should be made on the table before shifting the patient to the ICU. How do you advise that? Whether we should change over to a flexometallic?
Depending upon the patient condition, depending upon the prolonged surgery, if it is more than 6 to 8 hours, they are advising to keep the tube in situ.
Yes,
otherwise, the patient has got a oral pathology, oral oncology case.
Yes. Pertaining to
swallow. So there is more chance of aspiration. It's better if it is. Already we are sharing the airway. Both anesthetists and surgeons are sharing the airway. It's better for prolonged procedure, prolonged duration of the surgery. It's better to leave the tube in situ.
So, will you change over the tube? My question now, if you are having a flexible endotracheal tube, and then at the end of the surgery, you decide that we leave the tube in situ. In that case, will you change over to a flexometallic tube, or
no, after 48 hours only?
After 48 hours, yes. Because sometimes there will be a flap. Doing a laryngoscope will be tough in that situation. After 48 hours, you take the call after 48 hours.
Fibrotic bronchoscope guided is preferable.
Yes.
During the oral surgery or whatever flap you have done.
Yes. Okay. Next question. Anesthetic consideration for patients with Ludwig's angina.
Okay. It is a space infection is a very serious condition, and it's also a complicated situation which needs a focused examination. We have to examine whether it is airway problem is there, any airway edema is there. We have to examine the patient, and it needs a multi-specialty doctor's team. It is common usually dental origin. It is odontogenic in origin. Other causes will be the infected tonsil, parotid gland, infected lymph nodes, and also if it is neglected, it may land up in fatal situation. Ludwig's angina is a rapidly spreading gangrenous cellulitis involving submandibular spaces bilaterally without gland involvement. What are the causative organisms are Streptococcus viridans, Streptococcus aureus, E. coli, Pseudomonas, Bacteriaceae, Peptostreptococcus groups, and the rare causes are Provotilla melanogenicus, Provotilla viralis, Provotilla corrodens, and other non-specific mixed infections, both aerobic and anaerobic microorganisms are the cause for the Ludwig's angina. Usually it starts in the subgingival or peri-gingival packets, especially in the mandible, spreading to the submental and sublingual space. It all have common causes odontogenous dental infection from the second or third molar in the lower jaw, or dentomolar caries in the lower jaw. There will be other causes of other spreading infection from the other sides are submandibular adenitis, oral ulceration, wounds, acute epiglottitis, and then infected bronchial cyst, that is thyroglossal duct infection. Any injury to the floor of the mouth also can lead to the space infection. Then recent dental treatment, that is extraction of caries tooth without any protection, or immediately to do the tooth extraction without any undercover of antibiotics, they may end up in the space infection like Ludwig's angina. Other rare causes are tongue piercing, oral malignancy, secondary infection, AIDS, glomerulonephritis, diabetes mellitus, aplastic anemia, organ transplantation, etc. These are the other causes apart from the dental origin. Clinical features. The patient will present with a toothache and trismus, inability to open the mouth. There will be a bilateral browny edema like indurated swelling in the neck, especially in the submandible, sublingual, and submental region. There will be a double chin, bull neck. There will be a tightness of the skin with a blunt chin. And there will be a hot potato voice like that. They'll be having. There will be drooling of saliva, oozing of pus, cyanosis, dysphagia, dysphonia can occur due to the airway edema. And then patient will be having fever, malaise, and breathlessness, and also will be irritability if the infection spreads to the brain, meningitis. The investigation we have to do is CBC, complete blood count. There will be increase of leukocytes, that is leukocytosis. If we then we have to do the pus culture and sensitivity, to administer proper antibiotics, sensitive antibiotics to tackle the severe infection. And then X-ray neck for a soft tissue swelling. There will be thumb sign, that is elevation of thumb sign is indicated by elevation of acute epiglottis, and then airway edema will be there, and then panoramic view to rule out any caries in the oral cavity. And the ultrasound is to differentiate between the cellulitis, abscess, and lymph nodes. Then CT scan is done to see any bone anatomy, neck abnormalities, and MRI neck is to define the image of the swelling, and then oral examination to see for any caries or intraoral edema. How to manage a Ludwig's angina coming for a OPRL? There is two. So we have to differentiate between one with the patient with a severe respiratory distress and without any immediate airway edema. If the patient comes with a severe respiratory distress, tachypneic, breathlessness, and then with a fever like that, we have to do the first nebulization with adrenaline for bronchodilation. Then we have to intubate the patient either with the oral endotracheal tube. If it is not possible, we can introduce the LMA, and also we have to start the antibiotics and IV fluids, and then improve the hydration. And then in case of not able to intubate with the oral because of edema, oral everything secretion, we can try with the ideal is fiber optic bronchoscope. If it's not possible, we can try with the LMA or emergency. If it is the patient's saturation is going for very good, it's going for hypoxia like that, we have to do emergency cricothyroidectomy. But in the we have to puncture the cricothyroid membrane. We have to inject you can pass it with the dilatation. We can introduce smaller tube so that we can prolong the hypoxia not to occur. So next is we have to plan for immediately we have to do surgical tracheostomy. This is for the patient with a severe respiratory distress. If the patient comes without any distress or no immediate, if you examine the oral cavity, if there is no air edema like that, we have to nebulize the patient with adrenaline. Then we have to start an anti-inflammatory measures, and also you have to start an antibiotics as culture you have to do. Then you have to do the CT and MRI to see what extent the swelling has gone in. Then we have to plan for elective surgical tracheostomy and to keep the patient in the ICU. Management. Usual ideal is fiber optic bronchoscope is ideal method intubation in the case of Ludwig's angina, especially during emergency. Next is blind nasal. We should not attempt because they may puncture the bulging para-retropharyngeal abscess. They may occur in the terminal stages, and then the surgical tracheostomy is the immediate. If the FOB is not possible, we have to go for surgical tracheostomy. Or if there is no person to do surgical tracheostomy, you can try with the surgical cricothyroidotomy, but it is very difficult to prolong with the procedure to manage the hypoxia. Antibiotic available are injection amoxicillin with sulbactam 1.5 milligram, that is 50 to 100 microgram per kg weight IV in 2 divided doses, or along with the injection metronidazole 5 milligram TDS. Second generation cephalosporin, cephalotoxin we can use, that to 50 to 500 milligram per kg weight. Piperacillin can use along with the tazobactam. And if the patient has got a very penicillin resistant cases, we can try with the clindamycin. And then surgical intervention. Surgical treatment is you have to do T-shaped incision, that is bilateral incision. It is then bilateral incision is made below the mandible, that is at the angle of the mandible. This is followed by the dissection of the upper hyoid bone, and then incision is T-shaped, just 3 centimeters below the angle of the mandible. Then it is reached to the supraoid fossa, platysma divided, and then myloid muscle also divided. We have to do proper drainage and then drainage tube should be kept, and then we have to manage the patient in the ICU. Next, Sala.
Complications.
Any question?
But we can discuss on the complications. Complications we'll discuss on it. Yes.
Pneumothorax. Next is commonly encountered complications is pneumothorax because of spread, because of puncturing the abscess like that. A patient may end up in pneumothorax with a chest. It can be diagnosed with a chest X-ray. Immediately we have to introduce intercostal drainage tube. That is thoracentesis we have to do. Usually the patient with a pneumothorax will present with a pleuritic pain, cough, dyspnea, unequal breath sounds, and then tachycardia, cyanosis, and tactile thermitus will be heard over the chest. And then in case of pericardial intrusion and hypovolemia, we have to do pericardiocentesis. This can be found with the echo, by doing echo.
Yes. Yes. Thank you, ma'am. Thank you. Ma'am, when we take an MRI, if there is a shift in the trachea, so intubation is going to be all the more difficult. So in those situations, what is the call? And then regarding the fiber-optic intubation, again, we cannot give the laryngeal, recurrent laryngeal nerve block and the upper airway nerve block. We cannot give that.
Xylothrin spray you can give. Xylothrin spray and mild sedation with midazolam or fentanyl, dexmed also. In case of there is less of respiratory depression with the dexmedetomidine.
Yes. Ma'am, if the abscess and the inflammation is slightly spreading below the hyoid bone, when we talk about superior inferiority, and then from the lateral margin is coming towards the midline. So how do you decide that we'll intubate this patient priorly, or how do you decide whether it is based on the CT scan or MRI findings, or how the patient is progressing? How and when do you decide to put the patient under an endotracheal tube?
Usually depending upon the patient condition. Already so told me, patient will be coming with a severe respiratory distress. There is no time to decide it. No, there won't be any time to do MRI or CT scan. We have to straight away go with the FOB or tracheostomy. Yes.
Okay. Because at the very later stage, even tracheostomy might not be helpful. If it has gone, if the inflammation and the abscess has gone almost up to the clavicle, even tracheostomy would be a complicated procedure. It may be an abscess when we can encounter an abscess when you're trying to do a tracheostomy. In that situation, how do we tackle it? Pus can directly enter into trachea.
Enter into the lungs. Yes. But we have to, main criteria first is we have to secure the airway. Without that, we cannot prolong the patient. It may end up in the fatal situation like cardiac arrest, everything. So first we have to secure the airway. Yes. Then either with FOB or tracheostomy, no other go.
Yes. Yes, ma'am. Thank you, ma'am. Thank you for sharing your knowledge with us. It was a good time. So thank you to both the mentors for today, Dr. Shruti ma'am and Dr. Himarani ma'am. You have shared your experience with us. Hopefully all the PGs, few doubts on the topics what we discussed. I think they would have been very grateful to you. Thank you.
Thank you. Welcome.
Thank you, sir. You can stop sharing your screen.
Yes.
We come to an end of the session. On behalf of Tamil Nadu AOMSI, we would like to extend our heartfelt gratitude to the mentors and moderators for their valuable contribution and sharing their knowledge. The participants are requested to fill in the Google feedback form link, which will be posted in the chat box. The mentors and moderators may wish to leave the session. If they wish to leave the session, they may leave. Filling up this feedback form is mandatory for the participants to get the certificates. You'll get about 10 minutes to fill up the form. I once again thank all the mentors and the moderator, Dr. Himarani, Dr. Shruti
Welcome,
Rao,
thank
and Dr. James Bhagat for this wonderful session. It was really enriching for all the PGs. Thank you very much and see you all in the next session.
you.
Thank you. Thanks so much for having me over. Thank you, madam. Thank you, Dr. James. Thank you, Evelyn and ma'am. Thank you, Jimson sir. Thank you, everybody. Thank you, Dr. Kalpa. Bye.
Thank you,
Yes.
everybody.
Yeah.
Thank you, sir.
Thank you. Thank you for the organizing team. KK sir,
Thank you,
Jimson sir.
Raja sir. Thank you so much. Thank you, everybody.
Sir.
Thank you.
Anna? Oh, nah. Okay, only.
Thank you all. See you in the next session on Wednesday, 8 p.m. Thank you.